Hello, everyone. I am Carmel Shachar, the Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. I am delighted to welcome you to the event, Public Options for Employers. I think this is particularly good timing, hosting this event on the first full day of the Biden administration. The public option in healthcare has been something that has been discussed as a policy for many years, if not decades, but I think in the last several years has gotten a real traction in political currency. Joe Biden has a lot of continuity with the Obama administration, which famously put into place the Affordable Care Act, or the ACA, as you all know it, that really tried to push forward our health policy. We now have a new administration that is eager to tackle the pandemic, but is also eager to make more progress with healthcare. We are delighted to host three fantastic legal scholars who are working on what the public option might look like. I'm going to first introduce the authors of the paper that we will be discussing. In no particular order, it is Alison Hoffman, who is professor of law at Penn Law and also a former academic fellow of the Petrie-Flom Center. So we are very happy to welcome her back. Howell Jackson, the James S. Reed Jr. Professor of Law at Harvard Law School, and Amy Monahan, Distinguished McKnight University Professor, Associate Dean for Research and Planning, and the Melvin Steen and Corporate Donors Professor at the University of Minnesota Law School. They will be walking us through their research. After that, we will have responses from two people whose work has really put them, I think, on the vanguard of this issue and have a lot of insight into it. The first will be Judy Fetter, Professor, McCourt School of Public Policy at Georgetown University, and Institute Fellow at the Urban Institute, followed by Andrew Schwab, Director of Policy, Federal Affairs and Partnerships at United States of Care. At the very end, we will be happy to welcome questions from you for either the authors or the respondents. How do you ask a question, you might ask? There are two ways to do so. The first is to use the Zoom Q&A feature, which I will be monitoring and pulling questions from. That's probably the best way to do it. Of course, if you would like to join the conversation on Twitter, please use the hashtag public options. Again, that's hashtag public options. If you submit a question that way, Petrie-Flom staff will be monitoring the hashtag and will pull that question into the Q&A feed. Please do not use the chat function or the raise hand feature on Zoom. The raise hand feature is really cute, but that is not actually a great way to get your questions to us, and we would very much like to ask them of the speakers. With that, I believe that we have covered the logistics, and I hand over the event to our authors. I believe that Alison is going to start us off on a discussion of this interesting topic.
Thank you so much. It's such a pleasure to be here today and to share this project with you all. I look forward to your feedback and questions. So I'm going to start introducing this project and how we came to it and kind of the broad contours of it. Can you all see my slides? Good. Okay. So this project really grew out of the Democratic primaries, and what motivated it is we watched the extraordinary amount of airtime spent on health policy. We were watching two different camps form and thinking about what was dissatisfying about each piece of that conversation. And so what we saw was we saw one camp, President Biden. I have to adjust to saying President Biden rather than President-elect Biden today. President Biden, and it's a pleasure to be here talking about health policy at a time that we start to see really some productive and interesting conversations about what it will look like in the coming months and years. So President Biden was among the group that wanted to build on the existing system incrementally with a series of reforms to the Affordable Care Act. And a defining feature of this group was the use of a public option for individuals, that individuals could buy on the ACA exchanges or marketplaces. On the other side was a group that was espousing Medicare for all. Vice President Harris was among that group, and her policy included a 10-year transition period from the status quo to Medicare for all. At the end of that 10-year period, her policy envisioned that the population, that everyone would be enrolled in Medicare. So if you were watching these debates as closely as we were, what you would have, so this is the motivation for the project as we were all watching these different views. And if you were watching as closely as we were, what you probably saw was that sticker shock sunk the notion of Medicare for all. Even no matter how you account for the cost of it, it was big. And Howell will talk more about this, but what happens with Medicare for all is you account for the entire cost of healthcare spending on the federal budget. And from a policy matter, even if it saves money on healthcare spending at the end of the day, it scares people, even in its more modest forms. Now, if you think about the individual public option, which I'm sure we'll hear a lot more about in the coming months, it's a relatively small idea in comparison. So this is a snapshot of who remains uninsured now, 10 years into the Affordable Care Act. And what I want to point out on this slide is that even in its best case scenario, the individual public option just won't reach that many people. So if you look at the blue pieces on this slide, these are people who are eligible for Medicaid, but either haven't enrolled or their state hasn't expanded. The darker red pie piece are people who are ineligible due to immigration status, and a public option likely will not change that. There are some people in the upper right-hand corner of the lighter yellow who are eligible for subsidies on the exchanges, but they haven't enrolled. So what they need is subsidies. They need more help to get them to buy insurance. So when you start to think about who the individual public option will reach, what it will mean for gains in coverage, it's not that many people in total. Right now, if you think about the ACA exchanges, it's about 3% of the population who are enrolled through the ACA exchanges overall. The other theory is that the public option will be so good that it will change, kind of drive down the price of these plans, or it will cause the private insurers to offer better plans, cheaper plans, better quality plans. And in order for that to happen, the individuals you have to have a public option that's a lot better than those private health plans, which would be a great political climb, a great political feat. And then the people who are buying plans have to know that it's better than those other plans. And what we've seen through decades of research now is that we are really bad at choosing health plans. No matter where you look, if you look at research on Medicare, you look at research on Medicare Advantage, Medicare Part D, you look at research on the ACA exchanges, private health plans, people are notoriously bad at choosing health plans. This probably does not surprise you if you've had to do that own process of open enrollment or signing up for an ACA plan yourself. And so if people have a hard time identifying that the public option is better than alternatives, they don't kind of flee to it in large numbers, then it will have a hard time creating that larger structural change. So if you pull the lens back and you think about health policy experts, and even increasingly, I think health policy experts with lots of different political persuasions, they recognize that something that looks more like Medicare for all is a more efficient and equitable way to pay for health care than what we have today. And most people also agree we can't get there from here, even with something like a Harris-like transition plan, because of the politics of it, because of the sticker shock. And one thing that became quite evident during the debates is also because people are wed to their employer-sponsored health plans. In some case, that attachment is warranted. In some case, these plans are actually better than other options out there. It's what earned many of them the somewhat dated moniker of Cadillac plans. But in other cases, people are attached to plans that are not all that good and actually are becoming increasingly bad over time, as Amy will talk about in a moment. So either way, whether people should be wed to their plans or not, one thing President Obama learned the hard way is that if people like their health plan, they want to keep that health plan. And this kind of resistance is largely what motivates experts to focus on incremental reforms that they believe are more politically feasible and kind of less objectionable, even if they're more limited in scope and potential impact. So this is what motivated me and Howell and Amy to join forces And we started to brainstorm the possibility of a more incremental and organic way to loosen the tie to employer-sponsored health plans in the place where those plans make the least sense. What we're trying to do is put something out there that we think is politically and practically feasible as a policy option, and could also create that more structural change in the long run down the road. So the basic idea is to create a public option, likely based on Medicare, to offer to employers for their employees. The employers can choose to take up this public option instead of their private health plan. And by doing so, they start to loosen the knots that are binding the existing system, and they do it themselves at the employers and at the moment in time that makes the most sense. So what differentiates this from the more famous public option espoused by President Biden and Buttigieg and others on the campaign trail and in Congress is the focus audience. It's employers rather than individual consumers. And we think this is a better starting point for three reasons. So as I was just noting, individuals, we are not especially good at comparing and selecting among health plans, but we think that employers can be, especially large employers, which is where we think such a policy as an employer public option should focus. Large employers have HR departments and consultants who focus specifically on designing benefits and plans, and they could navigate better than most individuals can whether a public option is a good bet for the organization and for its employees. The fiscal case is stronger than either that for Medicare for all, and we think actually may be better than for an individual public option. How we'll go into more detail on that front. And then finally, it could produce a meaningful shift structurally towards Medicare for all, because employer-based coverage is where the people are. So if you look at this is a simplified version of the type of coverage people have today. About half of the population is in employer plans, about 154 million, as compared to 19 million who have those non-group individual policies now, and about 30 million uninsured. So if you could get even a few large employers to buy in, to choose this public option for their employees, and then if it worked and others followed, if it kind of catalyzed more to do so, it could have a tremendous structural effect. So we don't imagine necessarily that this would take us to a system of Medicare for all, but it could look like something like Medicare for more, and Medicare for more who would really benefit from being on a plan like Medicare rather than either uninsured or on an employer plan. So let me go one level deeper before I hand off to my co-authors. Here are the key policy contours. The first is that it would be voluntary. Employers would choose whether to opt in or to retain their current private plan. And we think this could soften employee resistance to it if it were offered by their employer rather than mandated by the government. It seems less encroaching on perceived autonomy. And Hal will also talk about how that voluntary aspect is very important from a fiscal dimension as well. We would target it early on, especially towards large employers, simply because they're a good distribution channel. The largest firms, 12,000 firms, have more than 1,000 employees, with on average 6,000 employees a firm. So even if you got a few of the largest firms to buy in, then you could start to kind of see real momentum developing. If you think about things like pricing and financing, the key in this area is that you would have to, and you could design it so that it's attractive to large employers, and ideally so that their employees are as well off or better off at the end of the day. So one of the pieces of that is that you could offer plans that cost them less. Medicare reimbursement rates, what they pay doctors and hospitals, is lower for the same services than what private plans pay now. So that could mean that overall spending for the employer goes down, even if utilization remains relatively constant. This could still be true if you increased Medicare's reimbursement rates, which presumably you would have to do in order to keep a broad network. But it could still, at the end of the day, translate into savings for employers and possibly for employees too, depending on how it's structured. In the longer run, it holds the potential to kind of reverse the decades of what we've seen, which is that healthcare costs grow and we see wage growth flattening out. So the increasing cost of healthcare is really having a negative impact on employee wages. If you think about the structure of the plan, benefits and cost sharing, again, it would have to proxy what generous large employer plans do today to have appeal to employers. In some regards, this would be easy if you could retain the Medicare coverage. It's quite extensive. You'd have to bolster it a little bit, thinking about for a working age population, but it generally pays for what is medically necessary. In other ways, it would be hard because Medicare has higher cost sharing, the dollars you pay and your deductible or your co-payments when you go to to get medical care than many of these large employer plans. So if you put it in technical terms, it has an actuarial value of about 73%. It pays for about 73% of all of the services it pays for, and some large employer plans pay for 90%. So the employees pay for only about 10% of the total costs. Again, I touched on networks, provider networks, and reimbursement rates. They're closely intertwined issues. You'd want to pay enough to retain the rich network that Medicare has today. And we think that can be done without raising the reimbursement rates all the way up to the levels of private plans. You could also think about fancy formulas and other ways to adjust reimbursement over time, depending on participation levels and kind of phase in. And then finally, portability. So an especially stark lesson of the past year is that tying health insurance to employment makes no sense when a health crisis and an economic crisis occur simultaneously. We already knew that this tie was problematic as we saw people move from job to job and have to shift coverage. Now we see even more so that in the worst of times, it really fails us. In the early months of COVID, 30 million people in the US lost their employer-based coverage, their health care. Many of them did pick up coverage elsewhere. They were able to sign up for Medicaid, they were able to enroll on an ACA exchange, but even then, they faced disruption in what hospitals and doctors are covered under their plans and in other aspects of their health insurance. Experts are estimating that unemployment will remain high. We saw new unemployment filings today were again quite high. And experts are estimating they will remain high even after the recession starts to abate. So having some kind of public option that is the same across jobs and perhaps also between jobs would smooth this kind of transition. It can also make sense as fewer people reliably have jobs that come with health insurance. So we think you could tie in more, and Amy will talk more about this, more part-time and gig workers into employer health plans if you design this thing right. Exactly how to do that, how to achieve that goal is complicated from a design perspective, but conceptually, we think it's a major plus of this kind of approach. Which takes us to a question we get often when we talk to people about this work is, will employers be interested? Will they buy in? And we think they should be for a number of reasons, which I will hand off to Amy to discuss.
Great, thanks, Allison. It's a pleasure to be with all of you today to talk about this project. So I'm just going to talk a little bit more about the employer side of the equation and reasons why employers might, in fact, be interested in this approach. So one thing we see is that employers are increasingly struggling to manage healthcare costs, right? So anyone that is sort of involved in this operation on the employer side knows it's a constant story every year of costs increasing and deciding how best to address those costs. One way they've managed escalating spending is to shift costs to employees. So on this slide, what you're seeing is increases in various factors over the last 10 years approximately. And you can see the cost shifting pretty clearly here. That top line, the orange line, are deductibles. They've increased 162% over the last 10 years. The next line, the green line, family premiums have gone up by 54%. When you look at wages, those have only gone up 26%. So what we're seeing is that employees are bearing more of the cost of healthcare, which is increasing. So that's employers already know this is a problem for them. It is difficult to manage these costs. Even when employers try to do better, even the ones that are best positioned to try to move the market find it very difficult. And we were actually sort of handed a wonderful example of this in recent weeks. So many of you may have heard of Haven Healthcare. This was a joint venture between JP Morgan, Amazon, Berkshire Hathaway, that was really trying to innovate in the employer-provided healthcare space. They had a lot of resources, a lot of interest. They cover a huge number of employees together, 1.5 million employees altogether. Just a few weeks ago, they announced about 3 weeks after they launched, or 3 weeks, excuse me, 3 years after they launched, that they were calling it quits. And the reason I say this is a good example for us is because it really gives us some important lessons about why it's hard, even for the best positioned, most motivated employers, to really move the needle on price and quality. So I just want to highlight a few things that Haven discovered when it tried to go about this. Cost transparency. So in reporting, this is mostly from the Wall Street Journal, in reporting on Haven's demise, they talked about the fact that, you know, even with the bargaining power of these huge companies, insurers weren't willing to share granular cost data with them. So if you're trying to fix a cost problem, that's hard if you really can't access the underlying data. Insurers, of course, took the position that this was proprietary and they weren't going to share it. So they couldn't really even get into the details of cost. Second, and really I think important for us as well, they didn't have enough power to move the market. So even the three of them together really lacked scale to garner enough negotiating power with insurers or care providers to really make fundamental changes. And there's one quote from someone who was involved, who worked at Haven, who simply said, "Healthcare was too big a problem for us to solve." I think that's really telling of the barriers that employers face, even if they want to make a change. So with that, let's talk about what an employer public option could offer to employers. The first one's probably pretty obvious here. A whole lot of reprieve, freedom from having to, on an annual basis, figure out what you're going to do about rising costs and exponential growth and the like. It could really lessen regulatory burden on employers. So the public option could be structured in a way where employers don't have to worry about ERISA at all, where tax code regulation is lessened, where things like HIPAA, COBRA, other things that apply right now are really transferred to the public option. So it's not something they have to worry about. It takes them out of the somewhat uncomfortable business of occasionally being in conflict with their employees about healthcare. The employer-employee relationship can be good in many ways, right? Some employers really act as advocates for their employees, but there are inevitably disputes, sometimes about life or death issues, and you are having those, if you're an employee, with your employer, if they're your health insurer. That can be really difficult in terms of workforce management and morale. And as Alison alluded to, it actually also offers a way where it really would make more sense for employers to bring in people they wouldn't otherwise cover. So dependents, we have pretty good coverage for them, but it's not universal. Dependents, but probably most importantly, part-time workers and gig economy workers. And the reason that we think it would be easier to bring those individuals in is in part because you're shifting a lot of the burden, but also because the public option offers a way to offer subsidies through the employer public option. So right now, there are no subsidies, no premium tax credits available for employer-provided coverage. To get those, you have to go to an individual market. And there are all sorts of good and practical reasons why that's the case. Probably most people also know that if your employer offers you what is deemed affordable and adequate coverage, even if you're low or moderate income, you can't then go to the individual markets and get a premium tax credit. But the employer public option could actually be used to rationalize subsidy design and let people who have employer public option coverage receive subsidies, much like the exchanges function right now. They could facilitate that process. In the interest of time, I'm not going to get into the details, but we can talk more about that in the Q&A if people are interested. Just a few things to highlight here. A few nice things about distributing subsidies through an employer public option. You get the benefit of employer outreach. So if your employer is saying, if you sign up for this, you can get these subsidies, it's a very convenient way to receive that message. And it also offers the simplicity of payroll deduction, right? So the subsidized premiums could be paid by payroll deduction, sort of simplifying that process as well. Also noted on this slide is the possibility of using this to fix what is known as the family glitch in the current subsidy system. Again, to highly simplify this, right now, the way eligibility for subsidies works, you can be made worse off if your employer offers you coverage because affordability is based solely on employee-only premiums. If you're trying to cover your family, that coverage might very well be unaffordable, but it sort of doesn't matter. You're ineligible for subsidies for your entire family if coverage is affordable just for the employee. We could fix that through the employer public option. But unfortunately, all these good things, it doesn't mean that employers are necessarily going to jump at the idea. There are some very practical impediments here. Probably the biggest one, in my estimation, is inertia, right? This is the norm. It's been the norm for a long time to have employer-provided coverage. There's going to be some stickiness there. Part of that is probably driven by C-suite employees who might really like their coverage, and they're the decision makers. There are various things we think you could do to combat that, in addition to this being a win-win for employers and employees. But one I'll just mention briefly is the public option could be base level coverage, which then could be supplemented, like we see sort of in Medicare. There could be add-ons to make the coverage more generous if that's desired. Some obstacles are fiscal and political. So I'm going to hand off to Howell to talk more about that side of things.
So thank you, Amy and Allison. And just move to the next slide. So as Allison mentioned, one of the big problems with Medicare for All proposals was the price tag, the trillions of dollars of new taxes that would be necessary. And if you just think about moving the employer-sponsored insurance from its current state into a Medicare for All proposal, that's half of individuals being moved, given the share of the GDP that's taken up with healthcare expenses. That is a big increase in the size of government with taxation and spending, and that just scared a lot of people. One of the interesting things about a voluntary public option, where companies can choose to come in if the product is attractive enough, is that's not a tax and spend program. It's in federal budget speak. It's the money coming in, the premiums that come in are offsetting receipts or collections for the federal government that cover the expenses. And so the only impact on budget aggregates would be whatever subsidies were provided. So if we included something that Amy was discussing about including some subsidies, that would have to be covered by general revenue or some other source and would be an increase in budget authority. But a very big advantage of this is by making it a business transaction that's voluntary, is lots of the money just, it doesn't really run through the federal budget. There aren't any taxes that have to be paid. And it just has a smaller footprint, the way the federal budget doesn't go up if you go into the post office and buy more stamps. That's just, those are business transactions that are just sort of seen in a different way and don't have the tax effect. The optics are better. It also simplifies the public debate. And if you remember those Democratic primary debates, there was a lot of discussion about labor market effects of imposing payroll taxes but reducing premiums, and wages will adjust, and this will be more efficient, and actually workers will be better off. And I can tell you from teaching this stuff, that's hard to explain in a law school classroom, what's going on there. And in some ways, the voluntary employer approach just sort of is elegant in that it eliminates the need to explain about labor market adjustments, because things look just exactly the way they looked before, that your employer is making a contribution, you're making a contribution. If we're right in our projections, maybe the cost of insurance will go down and wages will go up. If the subsidies are provided, maybe there will be a benefit, but there's just not this big adjustment that needs to be explained, and you need to make assumptions about how labor markets are going to perform. So I think that simplifies the public debate. It avoids some potential mischaracterizations, and it lets the advantages in terms of improved policy or subsidies of the sort that Amy was discussing, how they might be communicated, just kind of clearer and more salient. So it's a cleaner program to describe than Medicare for All was, as we saw in the debates. A final point that I'm just going to mention, that we've been working on this, it's not in the current draft of the paper, but if you're thinking about implementing this, one of the things you have to be thinking about is how does it get through Congress? And that's a ways down the road. We're just launching. We're one day into the administration. But if you think about the Senate side of things, the way this is structured, it is arguably, and we think likely, could be structured to go into a reconciliation bill, because it's all the provisions would be integral to changes in outlays and revenues, and that's one of the key things that the Byrd rule requires. So in contrast to Medicare for All and some other more dramatic changes, this might arguably be done in a way that would be easier to get through the Senate, which it is an important consideration in the current political environment. So that's one additional budgetary point that I just wanted to flag. And let me now just pass back to Alison to sum up.
I'll sum up in just a quick moment, because I want to hear from our respondents and questions from you all, but I'll finish with two quick thoughts. The first is that we don't necessarily think this idea is a short-term idea, although it could be if somebody who loved it picked it up and ran forward with it. And nor is it inconsistent with building on the ACA in the short term to fix some of the more pressing problems of uninsurance and underinsurance through some of the policies that President Biden has been talking about. But the point that we want to make clear is that even if those proposals plug some of the gaps in the current structures, they're not fixing foundational weaknesses. And so we think this idea in the long term could be a more structural and productive long-term solution to some of the issues that have been plaguing the way that we pay for, the way that we finance healthcare in this country for many years. And then the second thing I just want to be clear on is we don't think that this approach would be an easy lift, but no health reform is ever an easy lift, whether it is fundamental or incremental. And so even some of those incremental reforms that President Biden is talking about, like an individual public option, even increased subsidies, will face a fight in Congress. And so when we think about this kind of idea, we think it's worth that kind of effort and that kind of, kind of long-term work on kind of building up the constituencies in order to move this kind of policy forward. So what we're trying to do now with this project is to provoke thinking about the best path forward. And it might not be the right answer overnight, but it might also be that building incrementally on the system that we have now is not enough 10 years from now. And so this project is trying to find a space between those two extremes. With that, I will hand it off to Judy for commentary.
It had to happen once, right? So I'm now not mute, and thank you so much, Alison and Amy and Howell, for sharing with me your thoughtful approach to moving us toward universal coverage. You've done an extraordinary job and brought a lot of expertise and recognition of past successes, failures to your effort, and it shows. You know, I'm a veteran of health reform efforts, part of the government team that failed in the Clinton administration, and as a cheerleader and outside agitator in the Obama effort, which learned a lot from the Clinton failure. So not only do I share your goals, specifically your desire to effectively assert public responsibility to get everybody meaningful, affordable health insurance coverage, I also relate quite personally and powerfully to your strategic thinking in how to get around the obstacles to public responsibility that have inhibited our efforts to date. You've covered the bases in policy design and how anybody who pays this much attention to CBO scoring deserves a loud cheer and certainly knows what he's about. So I'm reacting to your proposal as a comrade in arms, if I may, and it's from that perspective, having been there where I think you are, that I want to start by explaining how I see your strategy as recognizing and relating to what we've tried before. Although in your paper, you say early on that our health insurance system is an accident of history, you correctly demonstrate otherwise, that our reliance on employer-sponsored insurance, heavily supported by the tax system, is the result of policy choices that were not so accidental. I'm a fan of Jacob Hacker's argument that politics got us here, that the failure of efforts to enact public health insurance early in the 20th century led to the emergence and then the entrenchment of employer-provided coverage and enabled opponents of public coverage to scare people that they had more to lose than to gain from government-run health insurance, alongside, of course, accusations of communism, socialism, and whatever else came to mind, which we continue to hear today. That fear of disruption led coverage advocates to build around rather than replace employer-sponsored insurance. That's how we got Medicare and Medicaid, limiting government programs to people left out of employer-sponsored insurance. It was reflected in our design in the Clinton administration, though we did in fact mess around a little bit with employer-sponsored insurance. And it is certainly true of the Affordable Care Act, which went to great pains to mostly leave employer-sponsored insurance alone, just fill in its holes through the marketplaces and Medicaid expansion. But you've decided it's time to get over that avoidance and take employer-sponsored insurance head on. And as you've explained, Alison, you've got good reason for doing so. Employer-sponsored insurance is becoming increasingly inadequate with its high deductibles. The pandemic has powerfully demonstrated its instability, and its costs are eating up wages. I'd add to that list my hope that today we are beginning an era when Democrats are ready to stand up for government and stop running away from it. But you clearly recognize that we're not all the way there. And that's why you're not looking at Medicare for all. You're looking for a serious government plan, the public option, but still, just like we were in the Clinton administration, you're looking to minimize disruption. Actually, your approach looks a lot to me like the strategies on the table before the Clinton era, the pay or play of Massachusetts, or the Pepper Commission that I directed under Senator Rockefeller in the late 80s that gave employers a choice: provide coverage or pay into a public plan for your employees. I know you don't have the employer requirements, but it's pretty similar in other respects. And you work very hard to make this option appealing or non-disruptive to employers. If I understood correctly, considering benchmarking the price for the public plan to what employers are already spending, benchmarking benefits to what employers are actually providing, and perhaps even letting employers choose to opt in for some of their employees and not others. I feel you bending over backwards to not be disruptive in order to overcome the opposition that has so hemmed us in the past. So I get why you're doing that, but based on experience, I have to say I'm not sure it's going to work. First, mirroring what employers are already doing is tough, complicated, and hard to justify. In all likelihood, and I believe you know most of what I'm going to say, but saying it anyway, in all likelihood, you're going to have winners and losers. Second, you're ignoring some powerful obstacles besides disruption. Disruption is one of the biggest, but it's also cover for providers who oppose public coverage, not because they're ideologically anti-government, but because their pocketbooks are anti-government. They are economically pro-maximizing their revenues. Now, I share your desire to tie provider payments to Medicare rates. Healthcare costs are eating up all our incomes, as well as our capacity to use public revenues for other essential purposes. And they're now getting 2 to 3 times what Medicare pays. Yes, paying Medicare rates will keep costs down, but those savings come at providers' expense, and they're not going to roll over so easy. In fact, I would argue you'd have to make them accept publicly set rates, like by tying them to Medicare participation, for example, to make it work. And then there's ideology. Even though employers would benefit from what you propose, and I listened to your arguments, Alison, and Amy, you're talking about inertia. I actually remember making very much the same arguments in the late 1980s. And I have found them, despite the advantages that employers might gain from giving up the responsibilities they now bear, they are pretty resistant ideologically to government-run programs. Opponents of Obamacare painted it as the end of the world because they are anti-government and anti-taxes or anti-redistribution. You've worked hard to keep costs off budget to avoid a big government or a tax hike look. But believe me, they're gonna give you a hard time about that. In the Clinton health reform effort, we thought we'd avoided disruption with our guarantee of broad benefits, offer of choice to employees where there was none, preservation of employer participation in the system, and exemption of the largest, most resistant employers. And look what they said about us: big government takeover and rationing care. Obama, learning from us, shrank what they did, and they still got that argument. That said, I am rooting for you, and I'm hoping we're in a different time. If we are, your creative policy design can help politicians navigate policy politics to all our advantage. But we can't engineer our way out of our fundamental political challenges. The real question is whether politicians are finally ready to stand up for the role of government to redistribute resources, assert public authority, and guarantee affordable coverage. I sure as hell hope we are. Thanks. Now I'll turn it over to Andrew. Is that what you wanted?
Yes, thank you, everybody. It's wonderful to be here with you. I will try to be as speedy as possible. I am Director of Policy, Federal Affairs and Partnerships at United States of Care in Washington, D.C., and offices also in Minneapolis. We are a nonpartisan, nonprofit organization working to ensure everyone has quality, affordable health care, regardless of social status, of health status, social need, or income. We are bipartisan, nonpartisan ideologically, and have leadership councils and a board of directors that reflects that. I think the first thing that I'd like to touch on is US of Care's interest in this and why we've been so happy to collaborate on some small level with Alison, Amy, and Howell on their paper. We have been working to pass public option legislation in the states of Colorado and Connecticut for the past 2 legislative sessions, and that includes this legislative session that's coming up. In Connecticut, which we all know is also the seat of health insurance in the country with all the big headquarters there, the chairs of the insurance committees and local advocates have designed a public option bill to address increasing costs. There is increased enthusiasm to moving it to the governor's desk in 2021, and the first hearing for a public option is slated in Connecticut and expected in the insurance committee next week. Connecticut's approach is to leverage that purchasing power of the state employee health benefit plan, and the state will pool that together with small businesses, nonprofits, and Taft-Hartleys to buy in. In 2020, Connecticut was one of the only legislatures across the country that picked up a sizable number of Democratic seats to increase majorities in the House and the Senate. And so political prospects are looking up there. And the governor is also up for re-election in 2022. He's a businessman and has a strong focus on strengthening the state's economy, and this might be part of that. Next, I kind of wanted to focus on, we did some public polling in the last 4 to 6 weeks, and what we found is that the public option is incredibly popular across demographics and across political ideologies. First off, the pandemic has accelerated this. 84% of American voters agree that we must build a better, more equitable healthcare system in the wake of COVID-19. That includes 93% of Democrats, 71% of Republicans, and 94% of African-American voters. People want certainty that they can afford their health care coverage. That's at 57%. 42% of voters have foregone health insurance in the past for those under 30 and not sought to seek medical treatment because of the expense. 63% of voters agree with the statement, people should have the security and freedom that dependable healthcare coverage provides as life changes. And that gets to the heart of what Amy and Judy were talking about in terms of tying health security to employment in the United States. 68% of the respondents in our survey expressed a concern about people close to them losing insurance because of loss of a job. And 22% were concerned about losing their own coverage due to a job change or to changes in their health status. And so when you put all of this together, you find out some very interesting things about how regular people are thinking about this. 84% of voters in Connecticut believe it is more important that we make changes to our current healthcare system as a result of COVID-19, and by a 3-to-1 margin, they support a public health insurance option. And there's good reason that they support that public health option, because as we've alluded to, what we call the job-connected health insurance paradigm is under extraordinary stress. It's 55% of the American health insurance, of the healthcare coverage system. We don't talk about it enough. And 36% of employees below salaries of $39,000 for a family of 4 are estimated to have access, even the choice of employer coverage, while 90% of people over $103,000 per year for a family of 4 do. And so you can see that this is very inequitable both on a tax system and an income system. White Americans are about 1.4 times more likely to have job-connected health insurance than African Americans or Hispanic employees. And then, obviously the tax incentive for this is also incredibly inequitable. If you make more money, you get a bigger discount to buy the same product as one of your colleagues who makes less money. And so all of that is creating, I think, a new focus on job-connected health insurance, and the pandemic is obviously speeding that up as well. Politically, as Judy also alluded to, the same special interests that were around during the Harry and Louise times in the early 90s are still around today. Hospitals are worried about their reimbursement rates under a public option. At the same time, I've been in this place, in this kind of space for 20 years now. I am now hearing more and more and more from large employers saying, why do I have to pay 250% of Medicare for the same services that the government is giving to seniors? That's a change. And I think that's why you've seen employer groups like the Pacific Business Group on Health and the ERISA Industry Committee begin to be a little bit more open to the idea of a public option. Perhaps the public option that Connecticut or Colorado is looking at, perhaps the public option that our friends who have written this paper are exploring, but a public option nonetheless. On top of that, the American College of Physicians, the American Academy of Family Physicians have come out in favor of some form of a public option. And these are providers that are on the front lines of medicine, and but they are also deeply dedicated to ensuring as much coverage for people in the United States as possible. And the big granddaddy of them all, the American Medical Association, has recently also come out with caveats and conditions for tacit support and some interest in a public option, which was obviously the primary health policy proposal of the Biden campaign. So hospitals want to know about their reimbursement, but they are getting far more than Medicare. Providers of all stripes are interested in the same thing. Anybody who makes any type of revenue from what I would call the healthcare industrial complex, pharmaceutical companies, medical device companies, insurers are interested in their role here and how they will be able to make profit inside of this system. I agree wholeheartedly with the professors that employers are the biggest key to any type of healthcare reform and are uniquely positioned to be able to be part of this debate. And I've started seeing some of them get off the sidelines, which is welcome news. But I would also say that there is a big disconnect inside even large employers between the CFOs and the heads of benefits, right? The CFOs in the board meeting are saying this is really, really expensive. The head of benefits is saying we recruit and retain talented employees utilizing these benefits. But it seems to me that there should be a way forward in some way to quote unquote split the baby so that perhaps maybe employers could offer benefits above and beyond the basic benefits of an employer public option to recruit and retain talent, which is obviously very important. Right now, I'll close with saying that I think that this is a state-based effort on some level. Howell's description of this possibly moving in reconciliation package is attractive and something that we should consider. But in terms of timing and process in Congress, the COVID relief package is going to be first and foremost among their minds. But I know that this is part of it. We just have to start to see how that starts to peter out as Congress begins to do its work.
You're muted, I think.
Thanks, Allison. So thank you, everyone. We are now going to do a little bit of Q&A. I'm actually going to combine about 3 or 4 questions, all of which are asking about the perspective of employers on this potential option. So people want to know, have you asked any large employers about the attractiveness of the employer public option, as sometimes employers will use their specific health benefits as a way to recruit or compete for talent. Somebody brought up the experience in Massachusetts where there was an attempt to allow employers to buy into Mass Health that was met with a lot of opposition from business leaders. Can you speak to where you see the role of employers in this potential initiative?
I can take the first stab at answering this, which is a really important question, I think a really hard one to answer accurately at this stage. So we have had some initial conversations with employers, and they raise probably the things that everyone expects them to raise, which is they know their health plan right now, they have feelings about how it helps them recruit and retain, and change makes them nervous, right? So I don't want to sort of sugarcoat this as it's going to be easy. But when you start to talk about some of the advantages that are present, I think things start to loosen up a bit, right? So if you're in a position where this plan has better benefits, has a broader network, has lower cost, or some combination of those, then it starts to change the equation a bit. And obviously this is going to depend on their industry and how they think about their labor market. But I don't think it's impossible. My sense, and this is just my sense, is the hardest thing is going to be getting those first couple to go. I actually think if you got even 1 or 2 large employers to sign on and people started understanding it more and having some experience with it, I think it would start, there's a real possibility it starts to shift a bit in the market. So not to minimize it, but I do think there's a case to be made, and there are going to be some employers who are willing to listen.
I want to add one quick thing politically, which is I think people who didn't consider Medicare for all a real possibility before are now starting to see that. And so things short of that are now more appealing than they used to be to kind of people who would have been resistant before. So I think that could help politically to get employers on board, because this is voluntary, they can opt in or out. And then if it works over time, you might see more becoming interested in it.
Just one point to make: it would just take a few individuals, CEOs who were committed to social reform and the Biden agenda, to get behind this. That could make a huge change, which is just contrasted to an individual option where you need millions of people make individual choices. This is you only need a couple, but there are big rewards for the first movers.
Oh, Judy, go ahead. I see that you raised your hand.
I'm just thinking you ought to talk to Haven.
So I'm going to end quickly with a lightning round. I see a couple questions actually about the provider side. Some people noting, do you think providers would be willing to accept reduced payments even if it's not quite as reduced as it might be if you just adopted a Medicare fee schedule? But then other people bringing up that some of the cost savings that you see in Medicare is because the payments are lower. And so if you're saying, okay, we're going to raise those payments to accommodate providers, are you undermining some of the utility of this public option?
So maybe let me say a quick word here, which is that I think some providers will resist, and I think there's very little we could do about that. And as Judy was saying, there's going to have to be some political will to push back. I also think some groups like the AMA that have traditionally blocked legislative efforts are not as powerful as they used to be. And so to tell a very quick anecdote from when I was a fellow at Harvard and I was teaching a seminar, on health insurance reform, and I had a young, organizer named Vivek Murthy come in, who's a friend of mine, and speak to the group about a group that he put together called Doctors for Obama, that then became Doctors for America. And they pushed on the AMA, and they changed the AMA's position on the Affordable Care Act. And the AMA initially resisted it really strongly, and then they pulled back because they were bleeding members to this other younger group of doctors who just had a different perspective on kind of balancing their paychecks versus larger social agenda and you know, kind of broader population needs. And of course, you know, many of you listening know that he's now, for the second time, the Surgeon General of the country and is leading the COVID efforts. So, you know, I think it's hard, and I wouldn't say otherwise, but I think we see some fissures that we didn't see when Judy was working on this necessarily in the Clinton administration.
So with that, I'm mindful that we are a minute past the hour. I want to thank everybody. If we were in person, you would no doubt be hearing resounding applause. That was fantastic. Thank you for a very, very interesting afternoon. Just my clapping because of the limitations of Zoom.
Thank you, everybody.
And Judy.
Thank you.
Great to be with you.